everybody. Welcome to the FYI series and the great Dr. Dan Friedman, who I'll be introducing in just a second. I'm Neha, one of the fellows. Just wanted, for everybody who's here and for everybody who may be watching online, this is meant to be interactive. I know Dan would like it to be interactive, and if you have questions, please, chime in. And if you could also complete the online evaluation, that would be really helpful so that we know as fellows what's useful for you and what's not. So I would like to introduce Dan Friedman, my friend. He is one of our superstar cardiology fellows at the DCRI, now in his second year. He went to Cornell for undergraduate and medical school training, and then went to Massachusetts General for internal medicine residency training, and now is in his fourth year of general cardiology fellowship with me. And next year he will be starting his first of 2 years of EP fellowship. And he is going to be talking about a very difficult but very pertinent and interesting topic of pacemakers, defibrillators, and ablation for atrial fibrillation. So welcome, Dan. Thank you so much for doing this.
Thank you. Is this mic on now?
That's on.
Okay, great. So thank you, Neha. So today I'm going to talk about pacemakers, defibrillators, and catheter ablation, with a particular focus on atrial fibrillation ablation because it's a very common ablation procedure and that it's an ablation procedure that we're very involved with studying here at the DCRI. Here are my disclosures. So the overall broad learning objectives are going to be to allow you all to have a better understanding of electrophysiology, to augment your understanding of an important research area within cardiology and here at the DCRI, but also to allow you all to have a better understanding of the common problems and potential solutions that may face you or a family member or a friend. In terms of the specific actual topics, I'm hoping to allow you to get a better understanding of basic pacemaker indications, system components, and function. Don't worry, this won't get to be too detailed. I'll keep it at sort of broad concepts. Also talk about the same for ICDs. And then finally, we'll talk about how ablation can be used to treat common arrhythmias, particularly atrial fibrillation. Okay. So first, I want to just go over the heart's electrical system. If you have an understanding of what the heart's supposed to do, then you can develop a better understanding of what happens when the heart doesn't do what it's supposed to do. And then you can develop an understanding for how pacemakers, defibrillators, and ablation can help. So this will be basic, but I do want to run through it. So for the normal heart, the normal electrical activation of the heart is required to make sure that the heart pumps, right? So you need electrical activation of the muscle that leads to mechanical contraction. And when everything is timed right, and everything is nicely coordinated, then you have blood flow, and blood flow is a good thing. People feel better with blood flow. So normal electrical activation originates up here in the right atrium at the sinus node. And the sinus node is our natural intrinsic pacemaker, and it's what controls your heart rate under normal circumstances. So it gets your heart rate up fast if you're exercising. It keeps it down slow if you're resting or you're asleep. And so the activation starts in the sinus node, and then it moves down through the muscle cells of the atrium where it reaches the AV node. Okay? And the AV node you can kind of think of as like a gatekeeper between the top and the bottom parts of the heart. Now, the rest of the sort of midsection of the heart, so the area around this valve here, the tricuspid valve, and this valve here, the mitral valve, is electrically inert in normal circumstances. And so electricity can't get from the top to the bottom part of the heart unless it goes through the AV node. Okay? And so that can be a blessing if the top part of the heart is going out of control. This AV node can kind of regulate things and make sure if, for example, in atrial fibrillation, the top part of the heart is going 400 to 600 beats per minute, the bottom part isn't going 400 to 600 beats per minute, because that would not be a good thing. That would not be compatible with blood flow. However, when the AV node and the components around the AV node are misbehaving and they're not conducting from the top to the bottom part of the heart, there's no other ways that electrical activity can make that journey. And so that can cause problems. Now the good news is that there are other parts to the electrical system. And as you get a little bit further down here, you'll see that there's these other bundles. We call the right bundle and the left bundle. And they help to make sure that electrical activity can get from the AV node to the rest of the muscle in the bottom part of the heart, so the ventricles. Okay? And sometimes if the AV node is misbehaving and it's not allowing electrical activity to go from the top to the bottom part of the heart, this specialized conducting system down here can actually function as a backup pacemaker. Okay, and that can be life-saving. So it's very important to understand the different components of the electrical system, and that'll allow us to sort of move forward and understand things and put it into context. Now, just the last thing I'll say before I move on is that when you end up having abnormal heart rhythms from the atria, so atrial fibrillation, that necessarily means that it's an abnormal arrhythmia that's from the top part of the heart. And when you heard of things like ventricular tachycardia or ventricular fibrillation, that involves the ventricles, the bottom part. All right, so now we're going to move on. So what's normal conduction look like on an EKG? So there's a few components to the normal EKG, and I don't want you all to get bogged down in the details, but I do think that going through this a little bit will be helpful in understanding some of the disease terms that, again, you or family members or friends may have, or maybe you've come across in your work at the DCRI. But so a normal EKG consists of a P wave right here, which represents atrial electrical activity, and then there's a QRS complex, which represents ventricular electrical activity. And the interval between the P wave here and the QRS is the amount of time it takes for the electrical activity to go through the atria and across the AV node and then to activate the ventricle. Now, the AV node is very insulated, and so we actually can't see electrical activity in the AV node on the EKG. Okay? But so a normal conduction is when you've got a P wave followed by a QRS in a 1-to-1 ratio with a rate of about 60 to 100 beats per minute. Okay? So now we're going to move on to pacemakers now that you all understand the normal electrical activity of the heart. So there's two overall types of pacemaker indications. One is for bradycardia, which means slow heart rate, and the other is for resynchronization. And I'll get into that in a little more detail later. We'll talk about the pacemaker system components, so the hardware itself and the pacemaker function. Okay. So this is an example of why somebody may need a pacemaker. So on the top right here, you see normal conduction. It's actually the exact same strip that I showed you before. I just wanted to include it up here for comparison's sake. So you can have sinus node dysfunction, so the main normal pacemaker of the heart is not working correctly, and that can come in the form of P waves coming infrequently but consistently, and you can see that right here. You can see that there's a lot more of these spikes here than there are here, okay? And you can see that the P wave is just happening much less frequently, but the rest of the heart is behaving. The AV node is allowing the electricity to go to the bottom part of the heart. Everything's just happening too slowly, okay? And the other variation that we oftentimes see is inconsistent electrical activity. And so here you see everything's marching along P, QRS, P, QRS, P, QRS. Everything looks normal, P, QRS, and then all of a sudden, no P wave. So no electrical activity, no blood pressure, and then finally the sinus node wakes up and you see a P wave again right here, okay? And then it sort of goes on business as usual until this happens again. And the reason why sinus node dysfunction is a problem is because it can make people feel poorly. People can faint, they can feel lightheaded, dizzy, weak. Usually, it's not something that is a fatal problem, and that's often because, as I mentioned, there's those backup systems at the heart. Okay. The next kind of conduction abnormality involves the AV node. So we just kind of go down the heart to talk about additional levels of problems. So again, so this is that same normal strip on the top. And here you'll see an example of what we call second degree AV block. So the problem is in the AV node, okay? And if you look, I've marked the P's and the QRS complexes. And if you look, you can see that the P waves are occurring at about the same frequency at about a normal rate. And the P waves, the sinus node, it's all acting appropriately. But you'll see that there's not as many QRS complexes as there are P waves. So every time the top part of the heart says, okay, let's prepare for a heartbeat, it does its thing, but then we have a problem in the AV node. Okay? And for this middle strip right here, every so often you see the P wave leading to a QRS, but then sometimes not. And then it goes back to conducting, conducting. And then if you were to look on forward, you'd see that intermittently the electrical impulse does not make it to the bottom part of the heart. Okay? And this down here on the bottom is a slightly more extreme example called complete heart block. And that's where there's actually no P waves that are making it from the top to the bottom. So there's no electrical conduction. And the reason why you're seeing these QRS complexes here is because, as I mentioned, the heart has a backup pacemaker a little bit lower in the heart towards the ventricles, okay? And so that backup pacemaker here is what's allowing the heartbeat to occur and allowing life to be sustained, okay? And so we can put in pacemakers to treat both problems, okay? And this is what the typical pacemaker setup looks like. It's called a dual chamber pacemaker. And the main components include, there's two leads. One goes in the atrium and one goes in the ventricle. So one up here in the right atrium, one here in the right ventricle. And then there's a pulse generator or battery. And the battery has the actual energy that's required to create the impulses, but it also has the computer chips that allow the pacemaker to integrate the information it gets and to pace when appropriate. So pacemakers go in by putting, and these are the standard pacemakers. There's other variations I'll touch on briefly later. But the standard pacemaker goes in by making an incision up here below the bone and putting the two leads, one for the atrium, one for the ventricle, into the vein here, and then advancing it down under fluoroscopic guidance, so meaning continuous X-ray guidance, down into the heart. And one lead goes into the right atrium, and one goes into the right ventricle. Okay, and so what that allows you to do is to pace on the top part of the heart. If the top part of the heart's a problem, like we saw with sinus node dysfunction, it allows you to pace on the bottom part of the heart if the bottom part of the heart is the problem, like we saw with AV block, because this part of the heart is the problem. Okay, or it lets you pace in both parts if both parts of the heart are a problem. And arrhythmias, conduction disturbances, they tend to go together in pairs and triplets and all that. So it's not uncommon for a patient to have multiple conduction problems. Okay. And in terms of the functioning itself, so each lead is able to do a few things. It's able to sense the underlying electrical activity. It's able to, by way of that generator, respond to the presence of an intrinsic rhythm however you program it to, and it allows you to pace if that's what the programmed algorithm tells you to do. Okay? And so these two lead pacemaker systems can just pace in one chamber if needed, it can just pace in the other chamber if needed, or it can do what we call AV sequential pacing. So it can mimic the normal electrical activity. So you can have, instead of having that sinus P wave and the normal QRS that occurs by virtue of AV nodal conduction, you can have pacemaker spike in the atrium, pacemaker spike in the ventricle, and all as well. And it can mimic the intrinsic activation pretty well, with some exceptions, but pretty darn good. Okay. So this is a slide with a few examples of normal pacemaker function. Okay. So in this top slide here, what you can see is there's a P wave right here, right here, right here. Okay. So there's normal activity in the top part of the heart. And the way this pacemaker is programmed is to track what's going on in the top part of the heart. And if we don't see conduction leading to a QRS within a certain programmed amount of time, the pacemaker paces. Okay? And since that AV node is not functioning adequately, based on our definition and based on how we've programmed the pacemaker, you see the P wave followed by a pacing spike, which is this big high-frequency spike, followed by this wider QRS. Okay? And so this is an example of the sinus node is working fine, the AV node is not working fine, and the pacemaker is picking up the slack. Okay? The second strip here is an example of when the sinus node is the problem. Okay? And in this situation, the pacemaker looks for a P wave, and if it were to see a P wave, it would not pace. It would let the heart do what it's trying to do. But in the absence of a P wave that occurs at a frequency that you determine as adequate, you'll see a pacer spike. And so here you see this pacing spike, pacing spike, pacing spike, leads to a small P wave, and then there's normal AV nodal conduction in a narrow intrinsic QRS. So in this strip, the only problem was the sinus node, and so you're only pacing in the atrium, and all is well. And in this bottom strip, you see an example of when both the sinus node and the AV node are the problem. So you see a spike here that leads to a P wave. It's kind of hard to see, but you can maybe see a little bit of a divot right here. That's the P wave. And then that's followed by a pacing spike in the ventricle. So that's AV sequential pacing. Okay? So these are ways that the pacemaker can be programmed to pick up the slack of the electrical system if and when it's needed. By and large, we'd like to avoid pacing unless a patient really needs it because there are some potential adverse effects associated with it, and it leads to battery drain, not surprisingly. So this is going to be a discussion of that other kind of pacer indication, the resynchronization indication. So what we talked about so far was for bradycardia, for slow heart rates, and this is a situation where you have a normal heart rate, but the problem is not the sinus node up here, it's not the AV node here. The problem is one of these two bundles, okay? Now, in order to understand why this is a problem, you need to realize that the specialized conduction system of the heart, so these bundles right here particularly, are able to conduct a lot faster than the heart muscles themselves. Okay? It's a lot faster and it's a lot more coordinated when your ventricles are activated by this intrinsic conduction system. And as a result, when you've got normal activation of the ventricles, your QRS complex looks like this up here on the top, where it's a very narrow, very high frequency QRS complex. Now when one of these bundles isn't working, you don't have that. One half of the heart has to get activated because of cell to cell to cell to cell conduction. And as a result, it's less efficient. It takes more time for the activation to occur. And so it makes sense that if you were to look on the EKG, it would take longer. So instead of this very narrow, distinct spike, it tends to be wider. Sometimes there's slurring, there's notching. And you can just tell it doesn't happen as quickly. And not surprisingly, if the electrical activation doesn't happen in a coordinated, synchronous manner, the mechanical function can suffer as well. Right? It kind of makes sense that if you're going to try and lead to an optimal pump function, you want everything to occur at the same time. You want the heart walls to squeeze against one another at the same time. If there's delay, then one wall squeezes and then the other wall squeezes. One wall squeezes and the other wall squeezes. And that is not efficient. It's not synchronous, and that can lead to congestive heart failure. A treatment for this type of dysynchrony is something called cardiac resynchronization therapy. Now, cardiac resynchronization therapy is very similar to the standard dual chamber pacemaker that we already talked about, except there's a third lead. So just like the standard pacemaker therapy, there's going to be a lead in the right atrium, a lead in the right ventricle. But in order to overcome the problem with that electrical system that leads to synchronous ventricular activation, we need a third lead. We need a lead that's able to pace in the left ventricle. That way you can have a pacemaker lead in both ventricles. And lucky for us, when the heart was designed by whoever you believe designed the heart, there is a vein in the back part of the heart that drains blood from the heart. So just like we have veins that drain blood from our arms and our legs and everywhere else, our heart has veins. And it just so happens that the main vein that drains blood from the heart happens to drain right into the right atrium. And so we're able to actually put a pacemaker lead into this vein, wrap it around the back side of the heart, so it's actually right over the left ventricle. So by adding this third lead, we can pace the right atrium, the right ventricle, and the left ventricle. So we can control the heart activation almost no matter what the underlying electrical system is doing. This therapy is a therapy that's mainly used for patients with a low ejection fraction, so poor pump function. It's able to overcome the abnormal electrical communication in the heart due to what we call a bundle branch block. And over time, pacing with this extra third lead actually can improve heart structure and function. So the ventricles can go from pumping like this to pumping like this. The ejection fraction, which is the percentage of blood that's pumped out with every squeeze, goes up. And the heart muscle actually can become healthier when measured by a number of different metrics. And importantly, CRT is able to reduce heart failure symptoms, improve quality of life, reduce heart failure hospitalizations, and improve mortality in certain subsets of patients. Okay. So CRT has really been a revolutionary treatment for patients with heart failure due to electrical problems. And this is just a brief look forward towards the future of pacemakers. So pacemakers, Achilles heel, and it'll be the same with defibrillators, are the leads themselves. Believe it or not, the blood vessels are a hostile environment. The heart is a hostile environment. Okay? Every time there's a contraction, all the blood flow, it can actually break down these system components. These components are at risk for becoming infected, so bacteria can attach to the leads. So there's all kinds of problems that occur because of the leads. Now these two little devices that you see are called leadless pacemakers. Okay? And one of these, this one right down here is the St. Jude device, and this right here is the Medtronic device. This is the NanoStim, if you've heard of it, and this is the Micra. As you can see, they're both very small, just a little bit bigger than a coin. And instead of implanting these through the chest and having long wires that go from the chest wall down to the heart, they actually get implanted with a catheter. You go through the vein in the groin, advance that catheter, which is basically a plastic tube, up to the heart. You position it at the tip of the right ventricle, so this is your right ventricle here, and then you release it, you pull this catheter out, and then what you're left with is this small little pacemaker in the tip of the heart. Now there's certain things that this type of pacemaker can't do relative to the other ones that we described. So it can't pace the atrium, it can't pace the left ventricle, so it can really only treat a very specific problem. And so as a result, we're still putting in mainly those long lead pacemakers, and we're reserving this type of pacemaker for very specific types of patients. But over time, this technology is likely to improve, and we're probably going to be able to have the ability to put one of these in the right ventricle, one into the right atrium, maybe one into that vein behind the heart, and so maybe one day we'll be able to actually do CRT without long leads. That'd be pretty cool. And it's probably, 10 years down the road, but it'll come. So exciting stuff. So some take-home messages about pacemakers. So pacemakers can treat slow heart rates due to the problem with the sinus node, the AV node, or both. Pacemakers will continuously monitor the heart rhythm, and they're usually programmed to pace only when the heart absolutely needs it. And we went over those strips showing how the pacemaker can figure out what's going on in the heart and pace just when it needs to. Pacemakers can also be used to treat abnormalities of electrical conduction between the ventricles. That's with that CRT third lead pacemaker setup that we talked about. And finally, over time, leadless pacemaker designs will likely improve to the point where it'll replace traditional transvenous pacemakers. So I'm going to move on to ICDs in a moment, but if anybody has any questions about pacemakers, I'd be happy to answer them right now. Okay, we'll move on to defibrillators. So defibrillators are similar to pacemakers in a number of ways, but very different in others. So we'll talk about what the defibrillator actually can do, okay, and we'll talk about the system components. So similar. And then at the end, we'll also talk about complications. And I say that to the end because a lot of the complications of pacemakers are similar to the complications associated with defibrillators. Okay. So this right here is an overview of an ICD design. As you'll recall, this looks very, very similar to what we saw before. The main difference is that this battery here not only serves as the battery in the computer chip, but it can also generate a shock that can reset the heart rhythm. And although the right atrial lead that you use for a pacemaker can be the same one that you use for a defibrillator, the right ventricular lead is different. And it has either one or two coils, which are used to actually deliver the shock energy. So with a pacemaker, you deliver a small amount of energy at the very tip of the lead, but with the defibrillator, you actually deliver the energy between this big generator up here in the chest and the coil, either down here in the right ventricle or up here, or both. Okay. So how does an ICD function? Like a pacemaker, it continuously monitors the heart. It knows what's going on at all time, 24/7. If a slow heart rhythm is detected, most ICDs can function like a pacemaker. This is a key point to remember. In contrast to pacemakers, if an ICD detects a fast heart rhythm from the ventricle, it can reset the heart through one of two mechanisms. It can shock the patient, as we talked about, using the coils and the actual can or generator. In certain situations, the ICD can also pace the patient out of an abnormal heart rhythm by rapidly pacing the ventricle. Okay? So there's two different ways that the heart can be reset. The shock usually always works. That pacing mechanism, which we call anti-tachycardia pacing, works some of the time. And you can specify how you want your patient to be treated. So all of these things are programmable. You can determine how fast of a rate is acceptable and how fast of a rate is too fast and you want to provide therapy for. And you can also specify what kind of therapy you program. So this is a brief overview of how an ICD thinks, and this is complicated, but I'm going to simplify it. So basically what happens is the ICD continuously monitors the heart, okay? And this is an example of a 2-lead defibrillator, okay? And this top lead is the signal from the top part of the heart. The bottom part right here, this is the signal from the bottom part of the heart. And what the ICD does is it takes each signal and based on information from each individual chamber and based on some other pieces of information, it determines what each little spike is. And so here you see a bunch of letters, and this is the device saying that they think it's one specific type of rhythm. And then right down here in the bottom, the same thing is going on. Okay? And so continuously, the defibrillator monitors the heart rhythm and basically decides, is what's going on good or is it bad? And if what's going on is bad, then after a predetermined amount of time, which again you program, you can deliver either that pacing or in this situation, there's a shock, and that's what this deflection is. And then you can see that right here before the shock, there's a fast rhythm, so lots of spikes over a short period of time. And after the shock, you end up getting the rhythm reset. Okay? And just based on knowing what these different labels are, the defibrillator is now happy with the rhythm as opposed to before when it shocked the patient out. So essentially what the defibrillator does is it takes all the information that we have given it in terms of programming, and it uses these algorithms to determine if what is going on is good or if it's bad. Because sometimes there's fast heart rates that maybe you don't want to shock somebody out of. So what if somebody's on a treadmill and their heart rate is like 180 beats per minute, and maybe that's okay. You don't want the defibrillator to shock the patient out of that, and so you want to make sure that the defibrillator knows what's what. Now usually the defibrillators work pretty good, but not 100% of the time, and that can lead to something called inappropriate shocks, which is when the defibrillator misclassifies a heart rhythm as bad when in reality it's actually okay. So that's an unfortunate complication of defibrillators and something that occurs about as frequently as shocks for bad rhythm. So sort of across all comers, you're about as likely to get a shock for a potentially fatal rhythm as you are to get a shock for a non-fatal rhythm, one that should probably be going on. So for example, a fast heart rate in the setting of exercise. So who gets ICDs? So before we talked about with pacemakers, it's patients who have conduction problems, right? So if you see somebody who has a slow heart rate for one reason or another, they have symptoms, then they should be considered for a pacemaker. Well, what about defibrillators? So when we talk about defibrillator indications, we talk about two different criteria. So one, there's primary prevention, and the other is secondary prevention. So primary prevention means that somebody has been determined to be at high risk for having a potentially fatal heart rhythm, but they have no history of such potentially fatal heart rhythm. However, based on some sort of risk stratification scheme, they're considered high risk, and we think that the risk of dying suddenly from one of these abnormal heart rhythms is so high that it warrants putting one in despite never having had one before. Okay? And the two main examples are patients with a low ejection fraction, so weak heart muscle, okay? And many patients with an ejection fraction of 35% or less qualify for primary prevention ICD. And some of the most important work that was done in this area was actually done through the DCRI. The SCUD-HEF trial was reported in 2004. It was a trial that was run by Gus Barty, who was a former Dookie, and that trial was run in collaboration with Carrie Lee, Denmark, and many others. And so a very important contribution to EP that came from DCRI and former Duke folks. The other population that's receiving primary prevention defibrillators fairly commonly are patients with hypertrophic cardiomyopathy. And what that basically means is these are people who have an inherited cardiomyopathy, so heart problem, that leads to very thick heart muscle. And that very thick heart muscle, you may think, oh, that sounds like strong, that sounds good. Well, the problem is when people end up having hypertrophic cardiomyopathy, there ends up being lots of scar mixed into the muscle, and it turns out that scar is a risk factor for having these abnormal heart rhythms. So those are the two main groups of patients who are getting primary prevention defibrillators. And about 75% of all the defibrillators that get put in the US are primary prevention. So that's the majority. Now, the other group of patients who get defibrillators are patients who get it for a secondary prevention indication. And that means those are people who have a history of a fatal or potentially fatal ventricular arrhythmia. So these are people who may have had a cardiac arrest that was resuscitated, or maybe somebody who walked into the emergency room and said, gee, I feel awful. And they were seen to be in ventricular tachycardia, and they had to get shocked out of it or paced out of it, or they had to get drugs to come out of it. One caveat is that we don't put defibrillators in patients with a history of a fatal rhythm due to a, quote, reversible cause. Now, the most common, or one of the most common causes of this is cardiac arrest in the setting of a heart attack. We know that heart attacks can predispose people towards these rhythms, and if we treat somebody adequately for the heart attack, meaning we open up the artery, then we think that they're no longer at high enough risk that it really merits putting in a defibrillator. And another common situation is someone who had an abnormal heart rhythm in the setting of an electrolyte disturbance. So picture somebody, a dialysis patient, who may have missed some dialysis sessions and their electrolytes or potassium are markedly abnormal. Those things are arrhythmogenic, and they don't need a defibrillator to treat that problem. They need regular dialysis to treat that problem. And so those are some examples of when somebody may have a fatal or potentially fatal rhythm that we would not treat with a defibrillator. So complications. So I already mentioned one complication of defibrillators, and it's a complication that's unique to defibrillators, and that's inappropriate shocks. Okay? Inappropriate shocks can be painful, they can be traumatizing, and there's some emerging data that they may actually lead to increased risk of death due to mechanisms that we, at this point in time, don't understand. Now, that's a long-term complication. In terms of intraprocedural complications, there's risk of cardiac perforation. So anytime you're putting a lead in the heart and you're screwing that lead in, you could imagine there'd be scenarios where you could perforate the heart, cardiac arrest. Pneumothorax, which is a situation where you end up essentially putting a hole in something called the pleura, which is this sort of sac that surrounds the lungs, and that can allow air to get into that space, and that can lead to a collapsed lung. Similarly, you can get blood in that space, just because, again, you're working up here by the top part of the chest at the top of the lungs. There's also risk of bleeding, infection, blood vessel damage, and clot formation. Okay. On the whole, these are safe procedures. The risk of a major complication, potentially life-threatening complication, is in about the 1% to 2% range. the risk of non-major complications. So maybe a bit of bleeding at the site, pain, et cetera, is a little bit higher, probably an additional 2 or so, 3%. So this is another example of a disruptive, exciting technology that was developed to overcome some of the limitations of the transvenous ICD. So right here on the left, you'll see a diagram of the subcutaneous ICD. So remember I mentioned that guy Gus Barty who ran the SCUD-HEF trial? Well, about 20 plus years ago, he had a new idea for a defibrillator because he knew that even though these transvenous ICDs were good, they had problems. And the major Achilles heel of transvenous ICDs and transvenous pacemakers are the indwelling leads and coils. And so what he thought was, hey, we have AEDs all over, and we know that AEDs work. And AEDs, for those who don't know, right, they're the defibrillators that you see in malls, casinos, gyms, etc. And you just take pads, you stick one on here, and you can deliver a shock to treat potentially fatal heart rhythm. He said, well, that's not all that reasonable for someone just to walk around with their entire life, you know, having these stickers on. But what about if we created a similar design, but just put it under the skin? And so about 20 plus years ago, and the story goes, he actually wrote the prototype down on a cocktail napkin. He started to think of an idea for an entirely subcutaneous ICD. And so you can see right here with the subcutaneous device, there are leads and there is a coil right here, but it's all under the skin. Okay? And so similar to transvenous ICDs, the subcutaneous ICD can monitor the heart rate and the heart rhythm continuously, and if need be, it can deliver a shock. And instead of delivering a shock using a coil that's in the heart or in the bloodstream, it just does it using a coil that's right here by the sternum under the skin. So kind of similar to the AED defibrillation mechanism. And again, here on the right, you can see in comparison to the traditional transvenous ICD. So this is going to be an exciting disruptive technology. Now, one of the issues, though, is that there's no lead in the blood vessel, so there's no ability to pace the heart. All you can do is shock the heart. So, you know, I said that most ICDs function as pacemakers. Well, this is the big example of an ICD that doesn't function as a pacemaker. And so if somebody needs, for example, both the pacemaker and the defibrillator, this isn't a particularly good option for them. So in summary, ICDs continuously monitor the heart. They provide therapies, either ICD therapy, so shocking or pacing, to get patients out of potentially fatal heart rhythms. And most ICDs, the exception being the subcutaneous ICD, can provide backup pacing too. So it can be both a pacer and a defibrillator. Okay? And I think over time, subcutaneous ICDs will likely replace transvenous ICDs as the subcutaneous ICD technology can be merged with that leadless pacemaker technology. Okay? And then you can imagine a situation where you can customize a device platform for a patient. So they maybe will develop a need for a defibrillator. You put in the subcutaneous ICD. And then you start to notice that their heart rhythm's a little slow. Well, then maybe you can add on one of those leadless pacemakers that can communicate with the defibrillator. And so you can imagine a time going forward where we're able to even better personalize device needs for a patient. Any questions on ICDs before I finish up with a brief chat about ablation? Okay, great. So I'm going to talk about catheter ablation for abnormal heart rhythms, and specifically going to focus on atrial fibrillation ablation. So in general, catheter ablation is a minimally invasive procedure where catheter energy is used to create burns that interrupt arrhythmia mechanisms. And these burns lead to irreversible scars that are unable to conduct electricity. Okay? So here you see, right here, there's a catheter. This is a schematic of a catheter coming up here. This little star is supposed to be abnormal electrical activity that's leading to an arrhythmia. And you put the catheter there, and then you turn on the energy. And so here's a picture of the catheter in contact with the heart muscle. Okay? And the most common type of energy that's used is called radio frequency. And radio frequency energy gets converted to thermal energy, which leads to irreversible tissue damage. And so here you can see The catheter tip is here, pressed against the tissue, radio frequency is turned on, and the lesion actually expands outward from the catheter tip. Okay, and here's a diagram showing, this is actually cryoablation. This is another kind of energy where instead of killing the tissue by heating it up and leading to a temperature rise, you can actually kill tissue by cooling it to negative up to here about 50 to even negative 75 Celsius. But the idea is that by delivering energy to the tissue, you kill the tissue and lead to an irreversible scar. Okay. Now, one key to all this, though, is you need to understand how the arrhythmia works, because you need to know where to burn. Because you obviously can't burn everywhere, and the more you burn, the more risk you have of complications. Okay. So what goes into an ablation procedure? The short answer is a lot. It's a pretty complicated procedure that requires fluoroscopy, which is continuous X-ray visualization, EKG monitoring, so the typical on the chest 12-lead EKGs. We put catheters up into the heart so we can continuously measure electrical activity in different chambers of the heart. We use electron atomic mapping, and I won't go into detail on this, but essentially what it allows you to do is it allows you to map the electrical activity inside the heart and create three-dimensional maps that represent normal and abnormal electrical activation. We use intracardiac echocardiography, so similar to the heart ultrasound that most people are probably familiar with, except you actually are able to mount the ultrasound probe on a small catheter and advance it into the heart, so you can use ultrasound energy to look at structures that are just a couple centimeters away. You need to use catheters for pacing and sensing, an ablation catheter like we talked about to deliver energy, and then a mapping catheter is used, and that interacts with that electrical anatomic mapping system to help figure out what's the anatomy of the heart chambers and what's the electrical activity doing. I won't go into any more detail about these specifics, but just understand that it's pretty complicated. It requires more than a standard cath lab. It requires multimodality imaging and continuous monitoring of the intracardiac and the extracardiac electrical signals. So what about catheter ablation of atrial fibrillation? So here on the left you see normal electrical activation, right? So it starts in the sinus node, it goes down towards the AV node, down into the ventricles using these bundles, and it goes across the inner atrial septum here and gets to the left atrium, right? It looks nice and organized, things work the way they should. In atrial fibrillation, in contrast, the top part of the heart has a chaotic, continuous electrical activation. So instead of it just having a continuous rhythmic contraction, there are multiple meandering electrical wavefronts that lead to a quivering of the top part of the heart. And if you all remember from Patty's talk a few months ago, that quivering leads to slow blood flow and predisposes towards clot formation and stroke. And since Patty talked all about that and talked about all the different ways to treat that, I'm not going to talk about anticoagulants right now, but I'm going to focus more on treatment for the rhythm itself. Okay. And as I mentioned, the electrical activity is chaotic and it's continuous. So instead of seeing discrete P waves here, you see this sort of undulating, chaotic baseline. Okay. And since the AV node doesn't get activated in a rhythmic, standard, stereotyped fashion, it gets activated intermittently, chaotically. You can end up seeing rapid, irregular rhythms. So one of the hallmarks of atrial fibrillation is a regularly irregular rhythm. And oftentimes it can be fast, because as I mentioned, the top part of the heart is going 400 to 600 beats per minute. And that can lead to a sensation of shortness of breath, palpitations, skip beats, syncope, etc. So in order to ablate AFib, we have to understand how AFib actually occurs. And in 1988, there was a very smart group of electrophysiologists from the Bordeaux region of France. They long knew that AFib could be started by a run of premature beats, so extra beats originating from the top part of the heart. What they thought is that, well, hey, if we're able to identify where these are coming from and prevent them from occurring, maybe we could treat atrial fibrillation. And so what these electrophysiologists did was they brought patients to the electrophysiology lab, they put catheters up in the heart, and they mapped the location of the origin of these extra beats. And this is a schematic diagram of the heart. So this is the right atrium, this is the left atrium. These four things are the pulmonary veins. Pulmonary veins are where the blood flow, the oxygenated blood flow, goes from the lungs to the heart, so it can then get pumped to the rest of the body. And what they did was they looked to see where all the extra beats were coming from in the heart. And each extra beat that they found is labeled here with a black dot. And so you see there's 3 over here in this part of the right atrium, but all of the rest of the beats, except for this guy, originated from within these veins. And so they thought, hey, if we can just prevent those extra beats from activating the rest of the heart, maybe we can prevent AFib ablation, or prevent AFib recurrence, excuse me. So this led to the development of a procedure which is the modern-day AFib ablation called a pulmonary vein isolation. So here you'll see a cartoon with a number of catheters up in the heart, but the things to pay attention to are that you've got these catheters coming up to here through the veins. You've got catheters going across the inner atrial septum. So you actually have to poke a hole through the inner atrial septum during the procedure. And this ablation catheter, sorry, I'm losing my cursor, is actually going to isolate these veins. That way, anytime you see a premature beat, it doesn't get out and negatively impact the rest of the atrium. And so the modern-day AFib ablation is built upon pulmonary vein isolation. So often people use the term pulmonary vein isolation or PVI synonymously with an AFib ablation. And here on the right, you can see a diagram of a completed AFib ablation, where there are 2 large circles that were created using catheter ablation that are isolating all 4 veins. And see all these little yellow dots? So this is supposed to represent electrical activity, fibrillatory activity that is contained within these ablation lesion sets, and therefore it's not impacting the rest of the atria and is not leading to atrial fibrillation. So how does AFib ablation work? So there's certain aspects of AFib ablation that are proven, and there are many more that are unproven. So the things that we know is that among patients who have symptomatic AFib were tried on an antiarrhythmic drug and still had AFib despite that antiarrhythmic drug, we know that catheter ablation is more effective than trying a second antiarrhythmic drug. By effective, I mean it reduces symptoms and AFib recurrence and improves quality of life. Okay? Now, the success rate depends on the kind of AFib that you have. If you're someone who has paroxysmal AFib, which is intermittent AFib that goes away within a week, either with or without treatment, then there's about an 80% success rate at 1 year. So 80% of people are AFib-free after a year. If you have what we call persistent or permanent AFib, which is AFib that has occurred much longer, so over a week continuously, then that success rate goes down to about 50%. And that has to do with some of the differences in the mechanisms that we think underpin paroxysmal versus persistent AFib. Now, some of the things that we're not sure about, we don't know if AFib ablation is able to reduce the risk of stroke, right? We talked about how AFib leads to stroke. Well, what about the successful treatment of AFib lead to stroke? Now, you'd think that the answer should be yes, but it's a little more complicated than that, and we don't quite know yet. We don't know if reducing AFib burden improves mortality, and we don't know if AFib ablation is superior to drug therapy for patients who've never had treatment for symptomatic AFib. So we don't know if it's a good first-line therapy. So based on that data and these complications, AFib ablation is typically not considered a first-line therapy. So AFib ablation complications are worth noting. So bleeding, blood vessel damage, perforation, or tamponade, because just like with the pacemaker and defibrillator implantations, you've got this metal thing that's by the heart wall, and you could imagine that if you're burning too much, you could potentially put a small hole in the heart, and that can be fatal. You can have damage to the electrical system, because obviously if you're burning too close to an important structure, it could be bad. pulmonary vein stenosis can occur. And that's because when you burn too close to those veins that have the electrical signals, they tend to contract down. And if you develop a blockage in that, you can develop symptoms, mainly dyspnea, coughing up blood, and that's a serious complication. But luckily, with newer ablation technologies, namely ablating large circles around the veins as opposed to going into them or going very close to them, that complication is now very rare. There's also risk of stroke or TIA. Again, you're burning in the left atrium, you're leading to charred tissue, all that is thrombogenic, could potentially increase the risk of stroke, the risk of cardiac arrest. And one final complication that I did not include on here is something called atrioesophageal fistula, which is where, after burning on the back part of the heart, you actually create a communication between the esophagus and the back part of the atrium. And that is almost, unfortunately, a universally fatal complication. The good news is that despite this scary list, the risk of anything serious or potentially life-threatening happening is pretty low, somewhere in the 1% to 2% range. And the risk of a minor complication is similarly in about the 1% to 2% range. So based on the efficacy and the questions about efficacy for certain endpoints, mortality, stroke, and the complication risks, right here you can see the way that we tend to incorporate AFib ablation into clinical care. So these are from the 2014 ACC AHA AFib guidelines. And basically, first-line therapy, based on all of the data that I talked about, is still drug therapy, so antiarrhythmic drugs. However, particularly among patients with paroxysmal AFib who are being treated at experienced centers, catheter ablation can be considered as a first-line treatment with a 2A level of recommendation. But again, that's for patients with paroxysmal AFib and patients who are at experienced centers, because we know that patients who have ablations done by electrophysiologists who do a lot of ablations, we know that they have better outcomes. So that gets to the Cabana trial. So the Cabana trial is a trial that's being run by Doug Packer at Mayo, being coordinated through the DCRI. Dan Mark and Carrie Lee are also playing major roles in the trial. And the trial itself is a trial comparing first-line antiarrhythmic drug versus first-line AFib ablation for patients with symptomatic AFib. Now, there's a few things that are very important. So number one, it's testing to see should we just be going straight for ablation and not mess with antiarrhythmic drugs, which, by the way, have a whole lot of complications themselves, which I haven't gone into. And then the other important thing is that this is going to be by far the largest trial of AFib ablation, and it's going to allow us to potentially detect differences in hard clinical endpoints. So not just AFib recurrence and symptoms, but the composite endpoint of this trial is a composite of disabling stroke, mortality, serious bleeding, or cardiac arrest. And so as a result, this is going to actually really help us to better understand when we should be using AFib ablation and what it can actually do for patients. So this is going to be a key trial, and Duke is proud to be heavily involved in it. Tris Bonson is the site PI, and he's enrolled 133 patients. We're the third highest enrolling center in the entire trial, including the US and abroad. And so this study, as I mentioned, is completed enrollment, and we're hoping for results. It's going to be still another, I think, 2 or so years, but hopefully soon we'll be able to learn about this and better understand how AFib ablation can help our patients. So in summary, for AFib ablation can electrically isolate the pulmonary veins and preventing those abnormal electrical impulses from leading to AFib in the rest of the heart. It can improve symptoms, AFib recurrence, and quality of life. There's a 1% to 2% risk of major complications. We don't know the effect of AFib ablation on things like stroke and mortality, but luckily we've got the Cabana trial, which Duke is heavily involved in, to help us out with those knowledge gaps. Does anybody have any questions? No? All right. Well, thank you.